The adenoids are behind the soft palate, which is here, the top of the mouth, the roof of the mouth, and the back of the throat. So kind of where they come together, that's where the adenoids are. This tissue is immunological, meaning it's going to help fight infection, and it responds to allergens, it responds to viruses, bacteria. The classic history is that a child was breathing fine when they were younger, and then over the years or months, they started to develop mouth breathing, nasal congestion, sneezing, recurrent infections. They also may snore or have obstructive sleep apnea. It just depends on the specific circumstance. And as you can see here, if the child is trying to breathe in, it is quite difficult. The reason it's difficult is that the adenoids are in that prime real estate in the back of the nose. How do we tell if the adenoids are enlarged? There are basically two main ways that we can tell. The first way is to do an X-ray. The child goes to the radiology suite, and if the adenoid area is enlarged, then we can track any interventions to try to shrink the adenoid size. The other way is to see an ear, nose, and throat surgeon. This is a handheld device that is placed into the nasal cavity. There's light at the tip that shines onto the adenoids, and the surgeon can view it in the screen. A is very small, B is medium-sized, C is large adenoids, and D are very large. The closer you get to having very large adenoids, the more likely the child is going to be mouth breathing. How do you know if the child has an infection? Typically, an infection will include fever, runny nose, possibly a cough, and mouth breathing. What happens if a child does not get treatment for chronic mouth breathing? If the nose is obstructed or blocked by large adenoids or other structures that are blocked inside the nose, and the child is chronically mouth breathing, you could develop what are known as adenoid facies or long face syndrome. There's no guarantee that the child will develop that, but in some cases they may. You could develop a high arched palate. Sometimes they'll have allergic shiners under the eyes on both sides. This could be a sign of congestion. Now, let's say a child does have large adenoids. What are the treatment options? The first option would be to obtain over-the-counter sinus rinses. Another option is antihistamines. These are oral medications, typically liquid or pills, just depends on the child's age. Nasal steroids are another option. Now, with nasal steroids, it actually takes time to build up, so you want to make sure to squirt the medication into the nostrils each side once or twice a day for several weeks. Another option is Montelukast. This is a medication that functions to decrease inflammation. So how is an adenoidectomy performed? Once the child is ready to go back, they will go to the operating room. They will get medication that helps them fall asleep. A breathing tube is placed, and the adenoidectomy is typically done with the mouth open and a headlight that's looking down into the mouth, and a mirror and a tool is then used to remove the adenoids. These are the three commonly used tools. The first is A, is called a coblator. B is a suction bovie. The last method is shown in letter C, and this is called a microdebrider. The goal after the surgery is, as you can see here, have just a small remnant of adenoid tissue so that the child can then breathe better. And you can see here now the air is able to go back. What are the possible complications? Typically, bleeding, infection, and need for more surgery. It is very rare to develop what is called velopharyngeal insufficiency, and that is where the palate may not close. Overall, the surgery is pretty safe, but before undergoing any medical management, any surgery, please make sure you fully understand the risks, benefits, and alternatives. A disclaimer: this video is strictly for educational purposes only. It is not meant to provide specific medical advice, so please seek professional medical assistance. The illustrations and content were created by Dr. Camacho.